you mentioned PI3 kinase inhibitors. Let's touch briefly on PI3 kinase inhibitors and their utility. Maybe Dr. Shadman, I can ask you what your thoughts are, what your experience has been with the PI3 kinase inhibitors. How do they fit in what we're doing today with therapeutic strategies in CLL?
Yeah, so when we think about the novel agents that we have for CLL, the three big groups are basically BTK inhibitors. That includes the next generation and now second generation, now third generation, and then of course we have the venetoclax. So PI3 kinase inhibitors are also there. I mean, they're in the toolbox that we use for CLL therapy. As John just mentioned, they're usually not the first or second choice most of the time. I mean, we know that based on their initial experience that using these agents in the frontline setting usually comes with more toxicity. And so basically these are treatments that we think about if we do in the relapse setting. So the initial, I mean, we have two approved drugs for CLL, of course, idelalisib and duvelisib. Idelalisib was the first drug that was approved. It's a PI3 kinase delta inhibitor. And in a study that was a randomized study that combined idelalisib with rituximab, and the control arm was placebo and rituximab. And the study showed PFS and OS benefit based on a relatively short follow-up. I believe that PFS was around 5 to 6 months for the control arm and not reached for idelalisib rituximab. And there was actually an overall survival benefit. I mean, the study population patients with abnormal kidney function, significant myelosuppression, and patients with coexisting issues. We recently, last year, we had a long-term follow-up published at the JCO, and it sounds like they looked overall for patients who received idelalisib and rituximab combo. The median PFS was around 20 months. I think what's, again, maybe the take-home point from this paper is really the toxicity data. As one of the factors that we consider for using or for not using PI3 kinase inhibitors is the toxicity, and namely colitis, pneumonitis, transaminitis, and as I mentioned, these are more, seem to be, some of them at least, more common in patients who are previously untreated, maybe because they have a more intact immune system. But when they looked at the long-term follow-up, sounds like with the longer exposure to idelalisib, the side effects like diarrhea, colitis, and pneumonitis actually become more common and more prevalent. For example, diarrhea, grade 3 or more diarrhea is in the range of 16% when you continue to take the drug, and even 17% grade 2. If you think about grade 2 diarrhea is having 4 to 6 stools per day, that is pretty significant. Same thing with colitis. I mean, for those of us who had to deal with colitis that resulted from idelalisib, I mean, in my experience, few patients that I had to treat early on, really treatment of graft-versus-host disease is the same type of approach with high dose of steroids and tapering. And, you know, for some patients, we had to go back on the drug because at the time there were not so many other options. So really significant toxicities. Pneumonitis sounds like 6% grade 3 or more with longer use. Hepatitis doesn't seem to be, usually we see it early on after starting therapy, and usually it's something that doesn't come back, and that the paper actually longer follow-up shows that and confirms that. Duvelisib is the other drug. It's a PI3 kinase delta and gamma that's also approved as monotherapy for CLL, based on a study that was a head-to-head randomized trial comparing duvelisib with ofatumumab. And again, a PFS of 13 months, 13.3 months versus 10 months for in favor of duvelisib led to the approval. I'm not sure how much this drug is used, so to know more about the true rate of toxicity, we need to use the drug, and beyond the initial clinical trial, we need to get more real-world data. But it sounds like diarrhea, colitis, I mean, these are reported separately in the paper, diarrhea and colitis. It's hard to really know what's the true rate, but to me, it seems the drug seems to have the same toxicity profile. Maybe the hepatitis is a little bit less. It's not reported. I mean, the incidence was less than 10%, but again, we need to use it more. And the drug has more indications. It's being used more in the T-cell lymphomas, for example, more recently, and maybe we get more toxicity information from different histologies soon. PI3 kinase inhibitors as a group are extremely effective. You just need to be, if you have to use them, we need to be mindful of the toxicity, mainly infections and basically autoimmune type of side effects and appropriate prophylaxis that needs to be used. There are strategies to make them better tolerated. And at the ASCO meeting, we had some, maybe we should call them next generation PI3 kinase inhibitors in terms of a scheduling. So giving them less frequently after an initial phase. So that one approach, we may have a PI3 kinase inhibitor that has a different toxicity profile that may be available for CLL and other lymphomas. Duvelisib, there are many studies in combination with the CD20 antibody and other combos. So I think we have some work to do from the toxicity standpoint, but in patients who I had on these drugs and even high-risk patients, it is an extremely effective medication as long as you control the side effects. Where I see them is usually as a third line in patients who either progressed on both BTKIs and venetoclax, or for some reason they can't tolerate them, and we do use them, and maybe there's a future in them in combining them with other drugs, and sounds like the future somehow involves a venetoclax-based therapy, and if BTKI for any reason is not a good partner, maybe a safe PI3 kinase inhibitor could be used. Drug-drug interactions are significant with PI3 kinase inhibitors and venetoclax, but again, there are studies that have shown safety for both duvelisib, and again, the newer generations are definitely studied as well.